Hello, doctor. Doctor, you are on mute.
Okay, so in general, the presentation would be a clinical palpable lump that would either be painful or painless. It would present with a nipple discharge, or it could be non-palpable and will just present with, for example, tenderness or erythema. Okay. Of course, with any mass, you have learned that method of diagnosis would primarily rely on your biopsy. Okay. So for benign breast diseases, our classifications will be the following. So aberrations of normal development, we have your pathologic classification, clinical classification, and clinical classification based on risk for malignancy. Okay. So for inflammation, most clinical important form of disease would be mastitis. So usually, this would present in a patient who is breastfeeding, presenting with cracks and fissures in the nipples, thereby causing your mastitis. Your mastitis is usually unilateral and could lead to abscess. So we treat by draining the surgical site, often under general anesthesia, and providing for antibiotics. Okay. Another inflammation would be your mammary duct ectasia. So your mammary duct ectasia would be common from your 5th and 6th decade of life, would affect your large ducts, and would be a symbol of chronic inflammation. Okay, although your underlying cause is unknown. So this could be poorly defined periareolar mass and could be confused clinically and even radiologically with carcinoma. So it could present as a thick cheesy nipple discharge with or without a mass and would present with skin retraction. That's why malignancy is a close differential. Hence, the need to know the differences between a mammary duct ectasia and between malignancy and normal inflammation. Okay? So another would be fat necrosis, though uncommon, so may be common in a history of trauma, surgical intervention, or radiotherapy. So this would be characterized by a central focus of your necrotic fat cells with lipid-laden macrophage and neutrophils. Okay. So major clinical significance, it's also a close differential with carcinoma because of a palpable mass and calcium ion seen on mammography with fibrosis. So your two inflammation, your mammary duct ectasia and your fat necrosis would be both close differentials for your carcinoma. Okay. When you are asked for most common breast disorder, and then your answer must be fibrocystic changes. So this would be alterations that are present in most women and there's no risk of progression for cancer. Question mark if it's due to hormonal imbalance. Okay. These are the features of your fibrocystic change. Usually presents in 20 to 40-year-old women, present as lumps, nipple discharge, densities. Okay, so we have different proliferative diseases. So aside from fibrocystic change, we have epithelial hyperplasia. So an increased number of layers of cell lining, ducts, and acini. So this would involve ducts and acini filled with overlapping proliferating cells. Okay. Sclerosing adenosis, so increase in acini as well. stromal fibrosis within lobules, and this can be associated with calcifications which may be detected on mammography. So that is without hyperplasia. Diseases, proliferative changes which present with atypical hyperplasia are epithelial hyperplasia characterized by atypical architectural and or cytologic features. Excuse me. Could you tell your classmates to join? It's interrupting the lecture that I have to admit people time and again. I will give you 5 minutes.
Okay, doctor.
No problema. Okay. Thank you. So, let me just admit a few people more. Okay. Ah, it does not end. Please tell them to join now. Okay. So it can affect ducts. Hindi. Okay, so this can affect ducts, atypical ductal hyperplasia, or lobules. Please tell your classmates to join in. We can have people trying to join in all throughout my lecture. It supersedes the PowerPoint presentation. We will take long if this would all be interrupted. Okay, so a typical hyperplasia would have atypical features that resemble but fall short of in situ cancer. So no diagnostic, clinical, or radiologic features. So incidence with the increased use of screening mammography and increased number of breast biopsies. Okay? Okay, so those are your proliferative changes. So Fibro Adenoma, so if you are asked most common benign tumor, who is writing on my screen? Okay, so if you are asked then for your most common benign tumor, then your answer should be fibroadenoma. Okay, clear? What's the most common breast disorder? That would be fibrocystic change. If it's asked most common benign tumor, your answer would then be fibroadenoma. So your fibroadenoma would be a circumscribed lesion composed of both proliferating and stromal elements. Okay, so this is an example of your fibroadenoma. Okay, so it presents in women less than 30 years old, and the classic presentation is that of a firm lump, and giant forms can occur especially in younger patients. It could concur with proliferative changes in the adjacent breast tissue. Approximately 20% would be complex fibroadenoma, and this would be characterized by certain special histologic features. Okay, so although the name sounds like it's malignant, duct papilloma is benign. So a benign papillary epithelial tumor that would occur in your large ducts. So papillae are fibrovascular stalks lined by layers of proliferating epithelial and myoepithelial cells. So most patients would present with a serous or bloody nipple discharge with again close differential to malignancy. Why is it important to know these changes? Because these tumors, even if it's benign, will pose as a relative risk for invasive breast cancer in the future. So how will this be determined? Okay, so you have your mastitis, fat necrosis, mammary duct ectasia. So despite it being a close differential to malignancy, your fat necrosis and your mammary duct ectasia would have no increased risk for invasive breast cancer. Same with your fibrocystic disease and your simple fibroadenoma. A slightly increased risk would be found in your moderate hyperplasia, sclerosing adenosis, a complex fibroadenoma, and a duct papilloma. Okay? Moderately increased would be your atypical ductal or your atypical lobular hyperplasia, bringing it about your carcinoma of the breast. Okay. So your carcinoma of the breast is one of the most common malignancy in women worldwide. So for women, it's breast cancer at the number one spot, followed closely by cervical cancer. This is for women alone, okay? So although in Asia, especially in India, it would have a low epidemiology. Okay. Risk factors, of course, with any malignancy, we will consider age. Risk factor, family history. So 10% would have genetic predisposition, especially if you have a mother or a sister who will have the disease. Okay? You have your genes, your BRCA1 and BRCA2. So these are mutations in tumor suppressing genes predisposing women to ovarian cancer and subsequently breast cancer. Okay. As mentioned, certain benign breast diseases, particularly your atypical lobular and atypical ductal, and a history of any other cancer for that matter, would be included in risk factors for breast cancer. Okay. So, hormonal factors, so any unopposed estrogen would increase your risk for breast cancer. Examples are listed below: early menarche, late menopause, nulliparity, low parity or obesity or any condition which would have estrogen conversion would have a risk factor for such. Environmental factors, so high fat, excess alcohol, ionizing radiation. Okay. Although etiology is unknown, Jessica, huwag ka maingay. So, please. So, this would be a combination of the factors that I've mentioned prior. Okay. So, for histologic classification, we have your ductal and your lobular. With this flow chart, you will see that most common histologic classification would be your intraductal carcinoma, followed by your ductal carcinoma in situ, and followed just by your lobular carcinoma in situ and your intralobular carcinoma. So, if you are to surmise what is the most common form of breast cancer, your answer should be intraductal carcinoma. Okay. So your ductal carcinoma in situ would be your increased incidence with increased use of mammographic screening and early cancer detection. So this would be the cancer that would be the most common in screening, meaning the lump is too small to be palpated, yet there are already changes in situ. So can also produce your palpable mass. So this is characterized by proliferating malignant cells within ducts that will not breach your basement membranes. So there are different grades. So there are high and low grade, and they are often multifocal. Okay. So women with DCIS are at risk for recurrent DCIS and eventually invasive cancer, especially in the same breast. Your LCIS is relatively uncommon. So this would be proliferation of your small uniform epithelial cells within the lobules. This would have an increased risk for invasive cancer in either breast. So this is the most common form of breast cancer, especially in the lower socioeconomic class. So this is increased incidence of screen-detected cancer, especially in developed countries. So this presents with a hard, irregular, palpable lump. So if this one is not screening anymore, your patient would usually come in to complain. So you will have the peau d'orange, that's the dimpling of the skin, and Paget's disease of the nipple, or that is your inflammation or insulation due to the intraductal spread to the nipple. Okay, so these are the clinical presentation. You will have your tethering, retraction, axillary mass, and metastasized distant. So your invasive ductal carcinoma will metastasize to your lung, brain, and bone. So you will see later on that your invasive lobular carcinoma would metastasize elsewhere. Okay. So distinct histologic types exist. Most common for your IDC is your serous carcinoma, which basically means your IDC of no special type. Okay? So these are your special histologic types of your IDC: medullary, tubular, mucinous, and papillary carcinoma. Okay. So your invasive lobular carcinoma is less common than your IDC. Will present similar features, but it's more likely to be bilateral and would have multicentric lesions within the same breast. Okay, so this would be the pattern: Indian file, This is strands columns within a fibrous stroma or around uninvolved ducts, which would be your bullseye pattern. As I've mentioned, your IDC would metastasize to your brain, lung, and bone. As to your invasive lobular carcinoma, it would metastasize more frequently to your CSF, serosal surfaces, and pelvic organs. Okay. So we have to know prognosis. So our staging system would be your TNM. So tumor size, node status, and tumor grade. Of course, increased tumor grade would have a worse prognosis. Okay. Depending on the presence or absence of your hormone receptors and certain molecular markers which may increase or decrease or worsen your prognosis. So treatment more often is mastectomy, breast conservation, plus or minus axillary dissection. So either followed by radiotherapy alone, chemotherapy alone, or hormonal treatment alone. Okay. So some special breast masses would be your Phyllodes tumor. This is a stromal tumor arising from your intralobular stroma. So this ranges in size from a few centimeters to massive lesions. So classically, you have a leaf-like configuration there by the name Phyllodes. So most are low grade that can recur locally but will rarely metastasize. So others are of high grade and exhibited aggressive clinical behavior and spread to distant sites. So this would be your cystosarcoma Phyllodes. Okay. And lastly, of course, the males would have breast as well, and enlargement of the male breast would be due to hormonal imbalance, primarily due to the presence of estrogen. So it could either be physiologic, seen at puberty or old age, or pathologic, associated with cirrhosis, or functional testicular tumors in general. Okay? So, gynecomastia in males is most important clinically as a marker of hyperestrogenism. But it's important to exclude neoplasia or malignancy so that you know that malignancy is certainly ruled out. Okay? Carcinoma in the breast of in the male could also occur but very rare. So this is similar to cancer seen in women. Skin involvement, since there would be no fatty tissue to show the skin dimpling, of course, skin involvement would be more obvious. Okay, so we have had this lecture for this afternoon. So these were our lecture objectives. Any questions for breast?
முடிய போல வேலை செய்து கேட்கலாம்.
No questions? Okay, so let us move to your gestational trophoblastic disease. Okay, so this is a trophoblastic disease which is common in the Philippines, in tropic countries. I don't know the incidence in India. Let me get back to you on that. Is it fairly common in India? Would someone know? Hydatidiform mole. So the learning objectives for this lecture would be the following. Okay. So it could either be benign or malignant. So your gestational trophoblastic disease would be would be a spectrum of diseases that would involve the trophoblast, and most commonly disease that we encounter for GTD would be your hydatidiform mole, either complete or partial. Okay? For this lecture and at your level, please concentrate on the difference between your hydatidiform mole and your gestational trophoblastic neoplasia. So others would be nice to know. Okay. So how is your hydatidiform defined? I'm sorry. So H mole is a general term that includes two distinct entries. So one is complete, one is partial, and features common to both forms include a hydropic state of some of all villi and trophoblastic proliferation. So these two forms differ on chromosomal pattern, histopathology, and clinical course. Okay. So you have pathophysiology, clinical course, histopathology, and prognosis. So what's the most common karyotype of a complete hydatidiform mole? So if you are asked this question, most common would be your 46XX, although your other would be possible also. So if it's partial, it's 69XXX, XXY, or XYY. Okay. So answer is XX. So risk factors for your GTD would be the following. So either extremes of age in the maternal side, increased paternal age, any previous molar pregnancy, diet, oral contraceptive use, and race. So question number 2. Okay, so this would be the classic presentation of course, answer would be hydatidiform mole. A patient presenting with 8 weeks amenorrhea, vaginal spotting with a positive pregnancy test, baggy corpus enlarged to more than age of gestation, no fetal heart tones, cul-de-sac full. So that is how hydatidiform mole is described. Why people are still applying to be admitted? Okay. So diagnosis, you have to retain a high index of suspicion based on clinical presentation supported by your typical ultrasonographic findings and an elevated Hcg titer, which we will see in our later slides. Okay, so for your diagnosis, you have a high index of suspicion when you have vaginal bleeding, you have your uterine size more than the age of gestation, there's presence of tecalutein cysts, hyperemesis gravidarum, preeclampsia, hyperthyroidism, and respiratory failure. So question number 2, answer is hydatidiform mole. So your ultrasound will show an overall sensitivity of 50 to 86%. So factors that may influence your diagnosis would be your gestational age, expertise of the operator, and type hydatidiform mole. So diagnosis for complete hydatidiform mole through ultrasound is diagnosed in 80% of cases, particularly during the second trimester when the grape-like or hydropic villus change occurs. And this is what is described as ground glass appearance. For partial mole, it's less accurate and as much as 70% of cases may be missed. This is due to the sonographer. If there's a baby present, we may not look for hydatidiform mole anymore. Two sonographic findings would be focal cystic changes in the placenta, and a ratio of the transverse to anteroposterior dimension of the gestational sac would be greater than 1.5. Okay. So as I've mentioned, serum beta Hcg would be an important marker. You have to correlate this with your ultrasonographic findings with your beta Hcg levels. So this can further improve the recognition of a molar pregnancy prior to surgical evaluation. Okay. So it has to be more than 100,000 units per liter. So this is associated with vaginal bleeding and uterine enlargement. This is highly suggestive of your complete H mole. In contrast, your partial H mole would have less markedly elevated values. But still, gold standard is histopathologic evaluation. There are other confirmatory tests as well. So your cytogenic examinations and immunostaining, particularly your P57 KIP2. Okay. So they differ histopathologically, behavior, but management is similar for both types of your HMO. Okay. So management would be doing this baseline laboratory examinations. So these examinations would be primarily for your vaginal bleeding, for potential blood transfusion, and for your potential complications such as preeclampsia, thyroid storm, and the like. So your other examinations would be your serum electrolytes, 12-lead ECG, ABG, PT, PTT, VT4, and TSH as needed. Okay. As I've mentioned, you have to evaluate and treat these potential medical complications. So anemia, hyperemesis gravidarum, preeclampsia, hyperthyroidism, respiratory distress, and DIC. Okay. So evacuation of molar products would be definitive therapy. It would confirm your pathologic diagnosis. It would relieve your symptoms and prevent complications. So question number 3. So ultrasound then showed a snowstorm pattern and beta Hcg was 164,000. What is the best mode of molar evacuation for your patient? She's a 27-year-old, primigravid, 8 weeks age of gestation. So what is your answer? So to answer the question, you must know that there are two possible management for your HMO. So primarily, if your patient does not have completed family size yet, you could opt for the ideal management is suction curettage. Hysterectomy is reserved for those who have completed family size, patients with life-threatening hemorrhage, and has a high chance of metastasis. Advantages of disadvantages of hysterectomy and medical induction are the following. So for this patient, recommended mode for evacuation would be suction curettage. Okay. Guidelines for such suction curettage would be the following. Cervical ripening would be done only through mechanical means. So no cervical by medical induction and the like. So mechanical, it's either you use a balloon catheter, you use your Hcg's dilator, or you use your laminaria. Your decalutane cysts are left alone during laparotomy. So Rh negative should receive Rh immune globulin, and all tissues obtained during evacuation should be submitted for histologic evaluation. Routine repeat curettage after the diagnosis of a molar pregnancy is not warranted. So this is important because risk of malignant degeneration for your complete mole is 15 to 25% compared to your partial mole, which is pegged at 0.5 to 4%. So especially those with signs and symptoms of marked trophoblastic proliferation, prophylaxis is needed. Okay. So medical chemoprophylaxis drug of choice is your methotrexate. So this is useful in situations where there's high risk of post-molar GTD and post-evacuation surveillance, which we will deal with later, is doubtful. So it does not remove the need for post-evacuation surveillance. So these are your indications for chemoprophylaxis. Age greater than or equal to 35, more than a G4, size 6 weeks larger than AOG, decaluteinsis more than 6 centimeters, complications of medical like your thyroid storm or your preeclampsia, recurrent mole, serum beta Hcg greater than 100,000, or you know that your patient would have a poor follow-up. Okay, all must have serial beta Hcg monitoring to detect malignant degeneration. So, for molar evacuation monitoring would be serum beta Hcg after a week, then every 2 weeks until 3 normal titers, then every month for 6 months, then every other month to complete 12 months. Follow-up is important to use a reliable contraception during the entire follow-up period, and pregnancy may be allowed after 6 months of normal HCG titers. Why would pregnancy be only allowed after 6 months? Why are you advised not to get pregnant right away? Anyone? Anyone care to answer my question? Anyone? Why do we advise our patients not to get pregnant right away? Anyone? So look for the answer. Okay. So risk of another mole after a pregnancy would be 1 to 2% after complete, 15 to 20% after 2H mole. So risk for stillbirth, prematurity, and the like is the same as your general population. So early ultrasound should be performed. Beta Hcg should be monitored at 6 weeks postpartum, and placenta should be submitted for histopathologic evaluation. Okay. So that would be the realm of your basic obstetrician. So there would be a specialty wherein they specialize in management of trophoblastic patients and eventually gestational trophoblastic neoplasia. So indications for referrals to a specialist, to a trophoblastic specialist would be high levels of beta HCG more than 4 weeks post evacuation either in your serum or your urine, a rise in beta Hcg of 10% or greater, or plateauing beta Hcg values. Okay. Any histological evidence of metastasis at any site, and elevation of a previously normal beta Hcg titer provided the diagnosis of pregnancy is excluded. Okay. So your other entities would be your gestational tuberoblastic neoplasia. Also presents as vaginal bleeding, anemia, uterine enlargement, predisposing one to tumor perforation. Okay. Initial tests would be the following. It will include your metastatic workup, including chest x-ray, CT scan, chest and your brain CT scan where your GTN would most often spread. So your patients must be staged and scored using the FIGO WHO prognostic scoring system, which is nice to know at your level. Okay. So management, histopathologic confirmation is not necessary to start treatment. So your chemotherapy is the principal mode of treatment. Surgery and radiotherapy are only adjuncts. So indications for hysterectomy would be removing a resistant focus, uterine perforation, profuse vaginal bleeding, or to reduce tumor load. Okay. So this is administered concurrent with chemotherapy done in cases of brain and liver metastasis. So advantage would be tumoricidal, it could be hemostatic, and has a synergistic effect with chemotherapy. Your Hcg monitoring for your GTN would be more often. So monthly for 6 months, every 2 months for 6 months, every 3 months for 1 year, and every 6 months thereafter. So if your mole would avoid pregnancy for 6 months, for GTN you avoid pregnancy for 2 years, and you must use reliable contraception. So important in this slide, your PSTT would be your implantation type intermediate trophoblast, and your ETT would be your chorionic type intermediate trophoblast. So your immunostaining differences, PSTT is diffuse with your cytokeratin and your human placental lactogen, and focal staining with HCG. So patients are classified using the FIGO system. Hysterectomy is the treatment of choice. Chemotherapy is given. So beta HCG is used to monitor the disease response to treatment, and would have follow-up protocol same as choriocarcinoma and invasive mole. Any questions with regards to your GTD and your breast? Are there any more questions? How many are you in class? So So I had 379 responses. Out of 5, you had an average of 4.8. Okay? So thank you for listening to the lecture. If there are no more questions, you may leave this call. I will end this call now. You may review this at our YouTube page if you want to go back to the lecture done live. Okay, thank you. Good afternoon.